Uh, Good afternoon and welcome to the 2026 AHS Research Summit. Today we have an important session on heart failure rehabilitation. We know that rehabilitation is not given that weightage in the Asian countries, especially in the low middle income countries. Rehabilitation, even though it is a cost effective thing, it is not given the due importance it should be given. So we have planned a good session covering all the aspects, starting from hospital admission to discharge to home care. So we have a series of 5 talks. We'll start with rehabilitation in hospitalized heart failure patients by Dr. Abraham Babu. He has done an RCT, randomized control trial, on the same topic. Over to Dr. Abraham for your talk.
Thank you, Dr. Harikrishnan, for the welcome and to the organizing committee for the opportunity to be here today. Sorry. Okay. Are my slides visible?
Yeah, your slides are visible. Please go ahead.
Okay. So thank you for this opportunity and welcome to everyone. Just a couple of acknowledgements to Dr. Akila Satyamurthy, who actually was involved with a lot of the work that we have done in acute heart failure and some funding that I've received from the Ansanda National Research Foundation. So I think we all know what is acute heart failure, but it's important, I think, for us to realize is what happens during that hospitalization. Now, from a clinical standpoint, I think the audience is very well aware about what goes on. But I thought I will shift your attention to what happens functionally to a patient. Now, this was a concept put forward way back in 2009, where it was shown that a person getting admitted to a hospital is going to have some degree of functional decline. Most patients, if they don't become dependent in their function during hospitalization, make a full recovery and go back. But we know in the setting of heart failure that many of our patients are those who actually become dependent in a lot of their activities while in hospital. Their trajectory of improvement slows down and is not as beneficial as it should be if they did receive rehabilitation. Now, many reasons account for this, and much of it is related to the immobility that is seen during that acute hospitalization period. And this causes a significant amount of muscle loss. And these change with different kinds of immobilization, but I think it's important to know that cellular changes in the muscle occur as early as 48 hours of immobilization. And of course, when there is bed rest, there is significant loss of muscle strength, and all of this impacts mobility and function. This is a model that was shown in pulmonary hypertension, where it was seen that patients who are optimized on medical therapy as part of the normal disease progression itself have their normal ups and downs. But with rehab, they do improve in terms of well-being. The ups and downs are still there, but they have done slightly better. And this is in the setting of optimized medical therapy. And this sets the stage very well for us to look at this wonderful paper that came out just last in the current issue of JACC, which talks about how management of acute heart failure moves on. And again, we do see that up and down trajectory here as well. And it is important that we need to start initiating rehab in the setting of guideline-directed medical therapy so as to ensure that these dips and are not as severe and we can still maintain function. So this is the premise, and I think a lot of what we do in acute heart failure comes from what we have seen from early mobilization in general critical care units. And this is a pivotal paper published in 2009 in the Lancet, where early mobilization in terms of early physiotherapy and occupational therapy did improve physical function in patients. And this was seen wonderfully in terms of the time to the first session, where it was started as early as 1.5 days after intubation. They had the greatest walking distance and they achieved functional targets within 4 days as against 7 days with the control arm. And I think this is very important to remember that in patients in a general critical care unit, early initiation of rehab shows significant benefits. Now, this is actually the premise that if we do start off mobility early, we can enhance physical function. So now let's come to the question is where does cardiac rehab fit in this? And I think it's very important that the recovery phase and the early post-discharge period are the golden periods to improve outcomes. And we are well aware of that. We have a fantastic trial that's also been published in the New England Journal just last year, which looked at how post-discharge management for acute heart failure actually improves physical function. And the World Heart Federation Continuum of Care and the Heart Failure Roadmap very nicely covers various aspects about how we need to think about maintaining the continuum of care. Now, what I would also like to add on to this is that cardiac rehab should be initiated at 2 points. And at both those points, you're also initiating guideline directed medical therapy. So it is important that cardiac rehab gets this referral both during the stable phase as well as during the initial diagnostic phase. So this is something which is extremely important. And I think you will see a lot of that coming up in our new rehabilitation roadmap from the World Heart Federation, which is due to be released on the 13th of July in Nature Reviews Cardiology and Global Heart. So please keep your eyes out for that. And just to give you a small idea about what is there, we talk a lot about capitalizing within the acute episode. And I think this is where the need for rehab during acute heart failure also comes in. The evolution of cardiac critical care, many of you would have seen this paper, is something that is taking priority these days. And it is important to have a collaborative interdisciplinary team that works within the cardiac ICUs to improve your patient outcomes. And I would draw your attention to the staffing requirements that have been proposed across. And you see that there is a need for allied health professionals, rehabs professionals, especially in physiotherapy and occupational therapy, across all the levels of cardiac ICUs. And these individuals are important, especially when we start to talk about early cardiac rehab in acute heart failure. So how has this evolved? I'm happy to say that one of the first trials was what we had done in 2011, way back then, and in a small pilot RCT, we had a very simple four-step progression for cardiac rehab in patients with acute heart failure. And it did show that, and the control arm received absolutely no intervention from a physical rehab perspective. And there was a significant improvement in 6 minute walk distance even at discharge. But what this did lack is that we didn't have very clear monitoring or termination criteria, initiation criteria, and so on. From this pilot RCT, that very same year, there was also a consensus statement from the Heart Failure Association and the APC, which brought out an algorithmic approach to managing acute heart failure and initiating early rehab. Again, going through all the way to discharge and also to referrals to home programs and phase two cardiac rehab. We built on our experiences over about from 2010 and 2008 to 2018, which is almost, and then we came up with a simplified algorithm, which also had various components of monitoring introduced into it. And we also use this as standard practice at our center, where patients with acute heart failure were being progressively mobilized once they were hemodynamically stable, and all of them were referred to a phase two cardiac rehab program. The Japanese Circulation Society in 2019 again came up with a six-stage approach, and this has been used in quite a few trials and studies that have looked at the effects of rehab. And again, as you can see, simple approaches to have been used from just sitting upright in bed to walking bedside, moving around, and of course, actually doing some degrees of more stressful exercises and also with walking tests. So this was something that can easily be done. And when we looked at literature that was published in 2020, there weren't too many trials that have looked at, just about 15. And it's interesting to see that in the last 5, 6 years that this number has actually doubled. So the interest in early rehab in acute heart failure is truly there. The ongoing trials have dropped a bit, but I'm sure this is going to pick up with greater interest in the years to come. This was a review we published earlier this year, which looked at what all has been done, and we were able to include almost 31 articles. And it's important to see that across most of the studies that have been reported so far, there was a lack of clear initiation, safety, and termination criteria. And this could be one of the reasons why we don't see it being used so much, and there's a lot of apprehension behind initiating rehab within the acute heart failure stage. Most studies that did use an early rehab initiated it with a median of about 4 days and interquartile range ranging from 2.8 to 5.5 days. So it's still quite a wide margin that we do see. And these algorithms actually lacked real-time decision making. And that was one of the things that we did see over time. But the increasing number of studies that we have seen jump from 15 to 30 is definitely encouraging. But how it is being delivered remains greatly inconsistent. And we did propose a model looking at various acute, subacute, and discharge phases to think about how we plan our rehab program and to ensure that patients are part of the continuum of heart failure care. And to that end, we developed an algorithm that was through an international Delphi panel. And we came up with various referral criteria for the physician to use as well once patients were stabilized. And this was followed by a physiotherapy evaluation that again had a structured checklist. And physiotherapists had the option to defer mobilization if they felt the patient was not ready and have refer back to the physician who would then reevaluate and see whether it was something that needed addressing or could still go ahead. Now, if the patient was ready for physiotherapy and mobilization, the patient was progressed from in bed to walking, as and also introduced aerobic and resisted exercises. And this were progressed based on a structured safety criteria. Now, this may look a little complex, but what we do see is that this whole safety criteria was designed purely based on clinical signs and symptoms. And this makes it extremely easy to use in a clinical setting. And it allows a lot of options to ensure patients are safe. As you know, heart failure patients change each day. Some days they are better than other days. And this gives the therapist the flexibility to be able to tailor the program in a safe and structured manner. We also introduced de escalation strategies and also termination strategies. And one important thing that we have always done here is to keep the physician in loop so that the communication is kept clear within the team and they know exactly what is happening to your patient. This does require various other strategies as well in terms of exercises, but we do offer training and you can either contact Dr. Akhila or I for further information. This algorithm has clearly addressed a lot of the gaps that have been seen, and especially when it comes to well-defined cutoffs for hemodynamics, clinical stability, and also around the de-escalation and how to de-escalate termination criteria and steps to take after termination of an exercise session. So this has truly met a strong need. And they have been feasible in various outcomes that we have seen in a pilot RCT. But more importantly, what I would draw your attention to is the fact that patients with the algorithm could actually exercise at higher and targeted intensities than the control arms. And at the time of discharge, they were actually able to achieve much higher levels of moderate intensity than those in the control arm. And when we looked at what were the reasons for termination of exercises, most of it in the structured algorithm was because they achieved their target intensity. So this itself tells us that patients are exercising at a fairly good intensity, which reaps physiological benefits. So what is the way forward that I see? I think most important is to look at using a standardized training algorithm, which can be used. And like I said, you're more than welcome to contact Dr. Akila or I. We do online sessions and asynchronous learnings. There are case scenarios and structured debriefing that help the participant to understand better. We've also identified various barriers and solutions to overcome them. And these have been mapped out quite clearly in terms of how we will reach healthcare providers. How do we actually look at measuring this effectiveness of our algorithm? How do providers adopt this in their setting? And how can we ensure fidelity is there, and how can we ensure that this intervention is sustained? And I'm very happy that the Asian Heart Society has actually taken an interest in this. And I think as a key stakeholder, you have a role to play to promote early rehab in acute heart failure. In terms of research, we do need to expand. Like I said, this is still very early stages. We need definitive trials to come in, and it's important to think about hybrid effectiveness implementation trials that are multi-centric in nature. You can also look at cluster trials. And in those with established rehab programs, I think it's important to also think about quality improvement initiatives to facilitate referrals and initiating early mobilization for acute heart failure. As part of the International Council for Cardiovascular Prevention and Rehab, which I represent as its vice chair, we also offer training and capacity building in cardiac rehab. And this is again online and can be done by any number of people. So, to conclude, what I would like to say is that early initiation of cardiac rehab during hospitalization is beneficial and required to ensure continuity of care. Clear initiation and termination criteria are now available to promote early initiation of cardiac rehab. The new standardized algorithm and safety checklist are feasible and acceptable across stakeholders, and I think it's important to build capacity in the delivery of this algorithm. With that, I also offer this special invitation to the Asian Heart Society to join ICCPR, and also to all the listeners who are there today, that there is an open call for papers on advancing cardiovascular disease prevention and rehab through education, which is part of the Patient Education and Counseling Global Journal, which is the open access journal. And for the inaugural issue, there are no open access fees. Thank you for your attention. You're more than welcome to contact me on these details. And thank you for the opportunity to be here. I welcome any questions that you have. Thank you.
Thank you, Abraham, for that wonderful presentation and very important aspects you have discussed. So, any comments or questions from the panelist? So, I'll start with asking one question. So, heart failure patients are prone to arrhythmias and they can have issues while exercising. So, what all? So, the physicians and the cardiologists themselves are little bit hesitant to initiate the patient on rehabilitation while they are in the acute phase. So, what are the methods which you suggest to circumvent that issue or that anxiety?
Right, sir. So I think one of the things that we have done in this checklist is also to have resting evaluations of rhythms being assessed clearly and stability in the last 24 hours before we initiate. That was one of the key factors that we looked at. Once they are being mobilized, we have placed a lot of importance on clinical signs and hemodynamics that are measured through blood pressure, changes in pulse rates, and symptomology. Uh, Patients who are stable hemodynamically and able to manage, we gradually progress. Any alteration in symptomology, changes in pulse rates, drops in blood pressure, actually trigger the de-escalation pathway. So we do de-escalate, and there may be times we may de-escalate slightly prematurely, but I see that as a safety factor and safety net that is there for these patients rather than waiting for them to actually have a major event. So these are clinical tools that actually minimize the use of too much of monitoring, because sometimes we do see that extensive monitoring triggers unwanted apprehension also among patients, and then they become a lot more hesitant to move. But we have been quite cautious in these parameters that we have chosen, and so far we have been able to actually de-escalate safely. Much more number of patients than if we were not using this algorithm at all. So I think it is that combination of both the clinical evaluations and assessments.
Thank you. Any other comments from the panelists, Dr. Sindhu or Dr. Ding? Dr. Shafiq, any comments?
Yes, I was wondering, the exercises prescribed are very simple, but in a critical care setting, the staff, whether these exercises will be monitored by the nursing staff, or will there be a special, dedicated staff to do these things?
So in most settings, sir, they are offered by trained physiotherapists who are qualified. Most of them have may have a postgraduate degree in the area of critical care or cardiopulmonary rehabilitation. So they're specified, they're trained in those areas. This particular algorithm, we also kept it simple in such a way that it could also be delivered by a physiotherapist with graduate qualifications. So the clinical evaluations have been kept to a very bare minimum. The pre-checklists have been designed in such a way that they can be easily identified from difficulty. We have kept it to be simple checklists of yes, no. I understand at this stage it may be quite conservative, uh, but I think the option is that they can be trained, and I think that's where the training in the use of the algorithm comes in, because they need to be trained in the particular way in the thought process of how to use the algorithm. And I think if that process happens systematically, we will be able to ensure that the way it is delivered is standardized. And then obviously the option would be, can we think about task shifting and task sharing? So would we be able to train nurses as well in the use of this algorithm? And probably it may be the complex cases that probably require a physiotherapist or someone in an exercise science background to come in and probably intervene. But your regular patients who are fairly stable, low risk, could be mobilized even by nursing staff.
So we will thank you, Abraham, once again. We'll move forward to the next
Thank you,
talk.
sir. Thank you.
Can Dr. Sindhu introduce the speaker and the topic? Dr. Yang, are you there? Welcome, Dr.
Yes. Could you see
Yeah.
my slides? Could you see
Yeah,
my
I can
slides?
see your slides. Yeah.
Okay, thank
So
you.
he'll
Thank
be
you very much.
speaking on quality of life in heart failure. Dr. Sindhu, can you please introduce?
Okay, shall I start?
Yeah, please.
Okay, so thank you very much for the introduction. So good afternoon, everyone. So my name is Mingming Yang from Department of Cardiology from the Hospital Nanjing, and I feel truly honored to have this opportunity to be here. And the topic I'm going to share today is quality of life in patients with heart failure. I have no disclosure to declare, but I'd like to take this opportunity to thank the organizer for the invitation. So I'm sure all of you are very familiar with the trials here. This is a summary of the pivotal trials in heart failure. Trials that reported controversial or neutral results are not included, such as TopCat and Paragon HF. So I'm not going to stop longer here because these are all typical trials. So, with all of these guideline-directed medical therapy, a common question or interest will be how much benefit the patient will get. So let's look at an example here. If we have a patient 55 years old with heart failure with reduced ejection fraction compared to traditional therapy, that is to say ACER or ARB plus beta blocker, using a comprehensive disease modifying pharmacological therapies will benefit the patient. This will be an additional 8 years of event-free survival and additional 6-year overall survival. However, heart failure patients need more than heart failure care, especially while we are living in an ever-aging society. Quality of life always matters, and it is the heart of the matter. So here comes the question, what is the health-related quality of life? It is subjective and multidimensional and includes physical and occupational function, psychological state, social interaction, and somatic sensation. It goes beyond direct measurements of population health, life expectancy, and cause of death, and focus on the impact of health status on quality of life. Here you can see three terms: quality of life, health-related quality of life, health status, and do all of them are all of them the same? And in fact, it is difficult to conceive or significant aspects of quality of life because they are mainly are partially affected by the health status. So the terms quality of life and health-related quality of life are frequently used interchangeably, and some definitions fail to differentiate between the two. So this slide, the studies having shown that patients with heart failure have worse quality of life when compared to normal populations and patients with other chronic diseases such as hypertension, Parkinson's disease, and cancer. So more importantly, many heart failure patients recognize that improving health-related quality of life is just as important as, or even more important than, extending lifespan, especially for those with relatively severe symptoms. So this is highlighted in a survey showing that 61% attach more weight to quality of life over longevity, with 9% and 14% willing to trade 6 months and 12 months respectively for perfect health and better quality of life. So what is quality of life from a patient perspective? It is the ability to feel peace and joy and to do what you want with people you want to be with. The higher your quality of life, the more you can do what you want and enjoy time with your family. So from the above, so we can see that there are many reasons that could direct us to assess the health-related quality of life of the patients. So quality of life is crucial for patients. It helps healthcare professionals understand the extent and specific ways in which patients are affected by health failure and how they cope. It is an important consideration in patient decision-making process. The level of importance individual patient plays on quality of life varies depending on the disease state and their current status at the time assessment. Payers and regulatory bodies focus on patient-reported outcomes, and quality of life can serve as a quality indicator. So this table summarizes the quality of life questionnaires that have been used in heart failure. This is classified in heart failure disease specific and non-specific questionnaires. The most commonly used disease specific questionnaires are on the left column. You can see that are KCCQ and MLWHQ, and the most commonly used generic one is EQ5D. Those are highlighted in red. So as we know, New York Heart Association class, this is physician report indicators, worst heart failure status, correlates significantly with patient-reported outcomes. The correlation was strongest with disease-specific questionnaires. However, you can see from the figure here, within each new AYHA class, there was a wide distribution of health-related quality of life summary scores. This table shows that there was a good correlation between all three health-related quality of life assessment tools. The strongest correlation was observed between the two disease-specific questionnaires, the MLWHQ total score and the KCCQ overall summary score. So this is introduction about KCCQ questionnaire. So KCCQ, this is FDA Center for Device and Regulatory Health certificate it as a medical device development tools, and FDA Center for Drug Evaluation and Research certificate it as a clinical outcome assessment tool for cardiovascular trials. It has 23 questionnaires, and the impact heart failure are summarized on 7 different aspects during the past 2-week record period. To improve its feasibility of use, the longer its 23 questionnaire can be reduced to 24 questions questionnaire. This is KCCQ 12, but it maintains the reliability, effectiveness, and prognostic characteristics of the complete questionnaires. Here, one thing I want to mention that while KCCQ 12 may be the best choice for clinical application, the KCCQ 23 questionnaire is more suitable for clinical trials because it has been recognized by the FDA because supporting clinical outcomes for labeling and instruction manual purposes. So this slide gives a conceptual mapping of the KCCQ questionnaire to different manifestations of the heart failure. From here, you can see the symptom scales include symptom frequency, symptom burden, and symptom stability. The symptom frequency and symptom burden from here, in combination with physical and social function scales, can be summarized to a KCCQ clinical summary score. And you can also see the KCCQ overall summary score, which is the combination of the KCCQ clinical summary score and quality of life scale. So this slide shows the illustration of the generic equifaculty questionnaire. It has 5 domains and one VAS score that is due to the time limitation today, I will just focus on the KCCQ score, that is a disease-specific questionnaire of the heart failure. The quality of life scores are affected by many clinical and demographic variables, such as AYHA class and left ventricular ejection fraction and heart rate. And also in HEPAF, this slide shows that BMI and log transformed NT-proBNP were associated linearly with worsening KCCQ overall summary scores. So here, this slide shows that besides the above-mentioned variables, and we have also shown that quality of life scores are affected by many other factors, such as aging, region, and comorbidities. And one phenomenon we have found that compared to other regions, patients in Asia have a better health status. And among all the Asian countries that involved in most recent trials, we observe that patients in Japan have the highest quality of life scores. And the quality of life is not only served as a self-reported outcome, but also an important prognostic factor. Here we can see that studies shows that lower KCCQ scores were associated with higher risk of the clinical outcomes irrespective of the region. So we have also reported that KCCQ domain scores and some individual scores are correlated with the clinical outcomes. For example, as shown in this slide, patients with better self-efficacy have a lower risk of the adverse clinical outcomes. Also, studies have compared quality of life in different heart failure phenotypes and found that patients with HEPAF reported lower mean scores in nearly all the domains when compared with those with HFrEF in the Paradigm HF trial, and similar results was also found with MLWHQ scores. So when we come back to clinical manifestations, we can see that peripheral edema was most commonly reported in HFrEF patients, and a third heart sound least common, and radiological cardiomyopathy was least commonly present in the sham-preserved patients. And the frequency of other symptoms and signs were comparable across the three component trials. So as the FDA have increasingly emphasized how it values patient-reported outcomes and clinical outcome assessment, including its recent qualification of KCCQ, clinical trials have increasingly used them to evaluate novel therapies. So the figure on the right shows that the number of the trials that have been increasing dramatically. And the figure below shows that the mean between group differences in KCCQ overall scores in random clinical trials, and you can see these are the mean scores in HFrEF, HFpEF, and also in the studies using both HFrEF and HFpEF trials. So to have a deeper investigation, here it shows that in the DELIVER trial, treatment with dapagliflozin increased KCQ total symptom score by 2.4 points at 8 months. In the DEFY HF and PRESERVE HF trials, dapagliflozin significantly improves KCCQ clinical summary scores after 12 weeks of treatment with consistent benefits across the full range of the injection fraction. And more recently, in the Fine Art HF trial, finerenone significantly increased KCCQ total symptom score by 1.62, and it has been updated in the 2025 Japanese guidelines. And also, the treatment of finerenone has also approved in China in the last few months. So, in addition, KCCQ can also be used in the composite outcome. We look at the clinical outcomes of major heart failure RCTs and how it's changed over time. You will see that in cases where non-fatal events occur, traditional analytical methods often overlook the impact of the large number of the fatal events, and improvements in symptoms and quality of life are often difficult to be included in traditional composite endpoints based on the mobility and mortality, and therefore frequently analyzed as independent endpoints. As we show here, Wing statistics integrate all of these outcomes into single composite endpoints, taking into account the clinical significance of each outcome, thereby providing a more comprehensive assessment of the efficacy. So here is a good example. So examined the effect of dapagliflozin compared with placebo on a hierarchical composite outcome, ordered as cardiovascular death, total heart failure hospitalizations, total urgent heart failure visits, and improvement or deterioration of KCCQ score at 8 months. The win ratio for the composite outcome is 1.3. So another commonly asked question is, what is SGLT2 inhibitors used in conjunction with the also the most recent very popular GLP-1 receptor agonist? So my answer here is yes. I think use of the combination of these two medications will improve the effect, since these two medications they work through different pathways. So also in recent years, and people are showing increasing interest in traditional Chinese medicine because recently many trials have shown that traditional Chinese medicine have good efficacy and safety in the coronary artery diseases, or diabetes, heart failure, etc., etc. So what where the traditional Chinese medicine have a good effect on the quality of life of the heart failure patients? And my guess would be yes. And also we are also having ongoing trials that testing the traditional Chinese medicine its effect on the quality of life in the patients with HEP patients. So this is just a pilot trial. If it shows positive, so we will go into a larger population. So this is a double-blinded randomized trial that comparing the each dropping pills with corresponding placebo in the patients with heart failure with improved ejection fraction at a 1 versus 1 ratio. The primary outcome is changes in KCCQ and also the change in the NT-proBNP. So to conclude, health-related quality of life is a patient-centered indicator used in clinical practice and trials to assess the severity of heart failure and its impact on patient function. And quality of life indicators help predict the prognosis of patients with heart failure, and their predictive ability is independent of geographic region. So improve the quality of life of the patients are core goals or heart failure treatment, and are equally important across the entire range of left ventricular ejection fraction. So validated heart failure treatments can improve quality of life, and patient-centered management must be integrated into all aspects of clinical care and serve as a guiding principle. So for patients with heart failure who have received standard guideline-directed therapy by the guidelines, combined use of the traditional Chinese medicine may play an important role in quality of life. Thank you very much.
Thank you, Dr. Dang, for that Yang, for that wonderful talk. Any comments from the Dr. Dew?
Yeah, may I ask a quick question?
Yeah, please.
Thank you. Thank you, Professor Yang. We admire your quality of life study very much. Can I ask a quick question that what is the important clinical importance of KCCQ? How many scores increase is clinically important? And is it applied to each domain of your evaluation of the KCCQs?
So thank you, Professor Tu. Thank you very much for the question. This is really a very important and nice question. So one comment I want to mention at the very beginning is that about the minimal clinical importance improvement in KCCQ, I think it's still controversial. It's still under debate. So I think generally we would like consider about like 5 point increase will be like minimally clinically important improvement. But there are some studies showing that 5 points improvement is still not that enough, because studies have shown that 5 points improvements in some studies, they're showing that is not correlated with the adverse clinical outcomes. So people now they think 5 points is minimally, like clinically important improvement, and 10 points would be like a moderate, and 20 points would be a large improvement. And there, so we are still carrying out a study that's in using the combined studies or large recent clinical studies, or the RCTs, but the studies are not fully published, but we have reported results in the 2024, I think, in the ESC conferences, and we have been showing that at least 10-point increase will be enough to be correlated with adverse clinical outcome, but 5 point is not that enough. But for the deterioration of the KCCQ scores, we have found no matter that 5 points or 10 points or 20 points deterioration or decrease in the score, they all correlated with the adverse clinical outcomes. So for now, from my personal perspective, I would think that the deterioration in the KCCQ is clinically important, and no matter like 5, 10, or 20, they're all correlated with adverse clinical outcomes. But for the improvement in the KCCQs, I think 5 point increase, as we all recognize nowadays, is still need more discussion. That I would like to say.
Yes, that's great. That's interesting. Any deterioration is bad, and how many is good is uncertain, right?
Yes, that's right.
Thank you.
Thank you, Dr. Sindhu. Can I ask Dr. Alicia Peak to introduce the next speaker and the topic?
Yeah, we may go to the third topic, which we invite Professor Yu Qinshen from Tongji Hospital. Her topic is development and the implementation of hospital community home exercise rehabilitation model for chronic heart failure. Welcome, Professor Shen.
Good afternoon, everyone. Can you hear me?
Yeah, great.
Okay. Thank you, Professor Du's introduction. Thanks for invitation. I'm so glad to have here a presentation. The topic is development and the implementation of a hospital to community to home exercise rehabilitation model for chronic heart failure. The following is an index 2 to 5 part. First, is about the background. As we know, heart failure has high incidence, high mortality, and poor prognosis. But we know that CR is cardiac rehabilitation can do a lot to improve high incidence, high mortality, and poor prognosis. Recent studies have demonstrated that exercise rehabilitation has the following effects on heart failure. Can improve exercise tolerance, enhance quality of life, alleviate depression, and reduce the risk of rehospitalization. Also can lower the risk of mortality and improve the heart function, and so on. As for the guideline, from 2016 to 2024, ESC guideline and HACC and the Chinese guideline all recommend the CR is the level, the recommended, is class 1 and the level A. That means that all of the patients has the recommendation of CR, also the exercise. But there are limitations in the implementation of CR. The low participant, global cardiac rehabilitation participant rate, alarming low, range from 10 to 30%. Even the supervised HF action trials, long-term adherence to rehabilitation programs were found to be less than 30%. The limit facts lie in: one is medical institutions factors, lack of sufficient awareness, standardized protocols, and professional training among healthcare providers. The second is patient, just like psychosocial economical burdens and physical limitation are key. Patient side barrier. The third is medical policy, just like insurance coverage, but now it's DRG, that's so on. In the future, digital information supported is combining hospital rehab and community rehab and home rehab. Is the future's cardiac model. The second part is the content. Is the last 6 to 7 years our study summarized. Summary. One is about prognostic model. We established the first CPT-based prognostic model specific to Chinese patients with chronic heart failure was developed to predict the risk of long-term all-cause mortality and all-cause hospitalization. That's a retrospective study. Total 547 patients were enrolled and randomly divided into a derivation cohort and a validation cohort at a 7:3 ratio. There are 8 predictors. They are age, atrial fibrillation, PCI, diabetes, peak-VO2, and heart rate, and 8 minutes after exercise, and the CRP and the uric acid, and can predict 1 year survival, 3 years survival, 5 years survival, and 10 years survival. This is nomogram for predicting death and hospitalization in chronic heart failure. According the prognostic model made an APP named called Shanghai Tongji CHF Risk Warning Management System. It's online. The second part is about exploring appropriate primary care technologies for heart failure. There are two technologies. One is a method linked tertiary and a community hospital for chronic heart failure. Exercise prescription was development in community setting. We use 6-minute walk distance was used to set exercise intensity at the anaerobic threshold level. This study has been cited in the Chinese expert consensus of 6-minute walk test. This is an equation total chronic heart the whole group chronic heart failure anaerobic exercise intensity equal to 0.81 and times 6 minutes walk distance exercise intensity, and the lower is reduced and mild reduced and preserved half. The second technology is use HRI. What's HRI? That the peak exercise, the heart rate, and divide into the heart rate at rest, and also SPP, the systolic blood pressure. Use the two parameter, the HRI and the SPPR during exercise can assess chronic heart failure patients' exercise tolerance, offering a simple method for exercise capacity evaluation in primary care rehabilitation. This equation. The third part, a pioneer study on established homogeneous exercise rehabilitation system for heart failure across hospital, community, and home setting. There are two maps. Left map is hospital, community, home homogeneous exercise rehabilitation action. That's action map for people with chronic heart failure. The right side is the risk identification map for the management of chronic heart failure. It's a helper for the doctor or physician in communities, hospitals. By this, we make certificate or computer software copyright and worker registration. And the worker registration is about to transfer the criteria and the roadmap. Established of homogeneous exercise rehabilitation system for heart failure across hospital, community, and home setting. We issued two group standards. One is CPET, another is 6-minute walk test. One for tertiary and the hospital. The 6-minute walk test is for the lower level, just like community hospital. That's for quality control. So we call it homogenesis. I compare about the invention, discover innovation. There are 5. One is the first CPT-based prognostic model for Chinese chronic heart failure patients was established to predict long-term mortality and remission risk. First in China to report that peak SBP times V over VCO2 have a better predictive value for all-cause mortality, chronic heart failure than V over VCO2 slope. The three development method linking tertiary and community hospital for chronic heart failure exercise prescription was development. Using 6-minute walk test distance to set anaerobic threshold equivalent intensity in community setting. And the fourth is that first to report HI and SPPR can be used to assess Chinese chronic heart failure patient exercise tolerance, offering a simple tool for primary care exercise rehabilitation. The fifth is leading the development and implementation of hospital to community to home exercise rehabilitation model for chronic heart failure. That's the third part technical evaluation. They are in national or international level and novelty. Compare with the international research. The model is compared with Mickey Risco. Also has Peakville 2, but others parameter is different. And the second is both model include Peakville 2, but different in other predictors and predict outcomes. The third is a method was development to link tertiary and community hospital for exercise prescription for chronic heart failure, international norm. HI and SPPR about accounting for sex, HBR, and other influencing factors, but international study without consider this parameter. About the last about the hospital community homogeneous exercise international now. Okay. The last part is about practical application. We in 2023 Shanghai Yunnan Corporation project on standardization promotion exercise assessment technology for chronic heart failure patients based on hierarchy care was successfully held in Kunming. Also, we established the expert workstation in community hospital and to promote the CR implementation. That's also we do the National Continuing Education Program. That's 220s the training course. That's social application about coverage healthcare institution 41 about patient benefit 21,000 training session about 20 that's 20 sessions healthcare professional training 3,000 to 4,000. Also by summarize the result that we can reduce the mass about 23%. Okay, that's all. Thank you so much. Okay, thank you for your time, your attention. Thank you.
Thank you, Dr. Shin. You have did a good job, and all of things you have done for 10 years. So, can I ask you a question? Did you meet some difficulties and to run of your system, referral system? So did you base it on your hospital or based on the support from the government? Thank you.
Thanks, Dr. Professor Dean's question is about a referring system.
Yes, it's referral system. I think it's a difficulty to run the system from the territory to the community if you don't have the government support.
Yeah. I think the ideal situation is for the CR in the future is automatic they are automated referring system, but in China there's none. No, we make a referring system, but just apply a small part community hospital. Yeah, just like we established the expert station. This like this community hospital. But in the future, I think it's government the task for the referring system. Yes, because it's in referring system, I think the most of all, the important thing is the risk stratification. Yeah, stratification 那tertiary hospitals that is a high risk, but the low level, just like community hospital, is lower risk, and even in home exercise, that patient also lower risk. So in the referral systems must define this risk stratification. So in our system, the referral system, they are covered the risk stratification. So that's, I think, is very important. And training system also is very important, because the capability in lower levels, just like community city, is low. So, but I think in the future, their capability can be improved much more. So that's all.
Thank you. Thank you, Doctor. This is a very good referral system, and I can feel that it can help the patients in community and how to say the physiology in the community to help more patients with heart failure. So thank you for your good job.
Thank you very much.
If there are any other questions from the Dr. Harry?
No questions. I think we are running short of time. Shall we move to the next topic? Dr. Ali Shafiq, can you introduce the next speaker?
Okay, we change to the next topic. So I would like to introduce the Dr. The next. Can you show me the next slides? Hello?
Hello.
Hello, can you show me the next topic?
Yes, Professor. Just please wait for a couple of minutes and okay, now you can see it.
So the next topic, next speaker is Dr.
I'm sorry， 我不能退出这个分享，怎么回事？我退出了吗？
不好意思，是这样的，因为我们共享了简历，所以可能挤掉了您的共享，然后您稍后再重新共享一下。这边先让丁教授介绍。
不是，我要退出，我要退出。
哦，好的，那我们这边帮您退出一下共享。
哦，好好好。Thank you.
Okay, next topic is frailty in patients with heart failure. The speaker is Dr. Yang Tang from the China.
Good afternoon, everyone. Can you hear me?
Yes.
Yeah, we can hear you. Please go.
Okay. Let me start with our topic, frailty in heart failure patients. My talk is structured into 3 sections. First, we will dive into the epidemiology of frailty in heart failure patients. The definition of frailty. Frailty is a syndrome characterized by heightened vulnerability to stressors and diminished psychological reserves. It contains multiple domains like physical, cognitive, social, and mental, and the most studied is physical frailty. The frailty is common in heart failure patients. This is a cohort study. We can see in the left picture that over 50% patients, hospitalized heart failure patients, have frailty, and the percentage raised with age. In the right picture, we can see that the frailty domains are often overlapped, and only 13% have no frailty. Then, frailty is associated with adverse outcomes in heart failure patients. No matter all-cause death and heart failure rehospitalization or all-cause death only, we can see that the more frailty domains, the more the risk of event occurrence. Then, frailty is intertwined with heart failure, which makes them become a vicious circle. Heart failure could get inflammation, sarcopenia, and malnutrition, which make it a high risk of becoming frailty. And then frailty, through its physical and functional limitations, cognitive decline, and polypharmacy, which could worse heart failure and increase the hospitalization of heart failure, which become a vicious circle. Then how do we evaluate and manage frailty in heart failure patients? Let's get our second section, the evaluation of frailty in heart failure patients. The left, there are some evaluation tools of frailty in heart failure patients. The left is the FRED, frailty phenotype. It contains 5 domains like unintentional weight loss, exhaustion, weakness, slowness, and low physical activity. The presence of 3 or more of the 5 domains means the one is frailty. The right picture shows the clinical frailty scale. It divided people into 9 levels. The 1 level is very fat, and the 9 level is terminally ill. This is accessed by clinicians. So the former is objective, but it's time consuming, and the latter is more practice in clinical background. Then the next is the frailty index, also named as Rockwood cumulative deficit model. It contains many components like physiological measures, comorbidities, laboratory measurements, quality of life, and even cognitive function. This frailty means that the more cumulative of these variables, the more high risk of frailty. But it is comprehensive to calculate this data. So this index, these tools are mainly used in post-hoc analysis of some clinical trials. The next is recently published evaluation tools, heart failure frailty soccer. This is mainly developed to calculate the frailty of heart failure patients. It contains 4 domains like clinical, functional, psychocognitive, and social. It contains 15 questions which contains all the 4 domains. This is designed to heart failure patients, but the external validation is not full. So the usage in clinical is not often. There are some dilemmas of frailty evaluation in heart failure patients. First, the inconsistent definitions and thresholds. The tools are rooted in different theoretical models, so the cross-study comparability is not used. Then the second is the feasibility. Some tools are more time-consuming or equipment-dependent, and some simplistic tools could not capture the full spectrum. Third is that the non-physical domains like cognitive, psychological, and social frailty are often neglected. The last is that there are some gaps from assessment to action. How frailty stalkers get drug titration, drug usage in clinic remains unclear. The third section is the management of frailty in heart failure patients. First, began the aerobic exercise. Here is a post hoc analysis of heart failure action trial. It contains stable half-RAF outpatients, which comparing aerobic exercise with ural care, and found that the event of primary composite, let's look the red boxes, the event of primary composite endpoint and all-cause hospitalization are decreased in frailty participants, but not in non-frail participants, and the P4 interaction is 0.04, which means that frail heart failure patients derive greater event reduction benefit from aerobic analysis. The next trial is the Rehab heart failure trial. It contains 349 elderly heart failure patients, and 97% is frail. The intervention contains multiple domains, rehabilitation of strength, balance, mobility, and endurance. The primary outcome is SPBB soccer. There are functional outcomes, and it also contains other functional outcomes like 6-minute walk distance, KCCQ, frailty status, and depression. We can see that picture. We can see that the SPBB soccer and 6-minute walk distance are more significantly improvement through physical rehabilitation. But when it comes to clinical events, there are no significant differences in all-cause mortality, all-cause hospitalization, and heart failure hospitalization. Here is a post hoc analysis of the Rehab heart failure trial, which divided patients to half-RAF and half-PAF. The blue bar is half-PAF, and the red bar is half-RAF, and we can see that the functional outcomes of SPBB soccer, 6-minute walk distance, and quality of life are all higher in half-PAF patients, which means that compared to patients with half-PAF, compared to patients with half-RAF, those with half-PAF may derive greater benefit from the intervention. Then the drug and device therapies. Right now, there are no randomized clinical trials mainly designed in the frail heart failure patients. the data we get of the drug and device mainly comes from post hoc analysis of landmark trials. Here are some trials and the post hoc analysis. We can see that the drug like ANI, SGLT2 inhibitors, and phenylephrine and others can get a consistent benefit across all frailty groups. It means that although the patient is frail, it can also use this drugs. Then the last row, the ICD therapy, we can find that only low frailty HFrEF patients could get a benefit, and high frail patients could not get some benefits. There are some dilemmas of frailty management in heart failure patients. One is the usage of guideline-directed medication treatment of heart failure. We can see the left picture. The usage of ACEI, ARB, beta blocker, MRA. The frail patients are not on treatment is higher, and the non-frail is lower. When it comes to the triple therapy, about 57% usage in non-frail patients, but only 39% in frail patients. Further, even we prescribe these drugs, their doses are suboptimal. In the right picture, we can see that the darker color means the higher percentage of optimal doses. And we can see that the more frail patients, the more suboptimal usage of the doses. There are also other dilemmas of frailty management. First, cardiac rehabilitation underutilization. Only 10% of hospitalized heart failure patients are referred to cardiac rehabilitation. The main barriers contains high costs, transport issues, and limited patient awareness of this treatment. Second, heart failure and frailty form a vicious circle, which could accelerate the other through physical and functional decline. Third, frailty patients all have higher comorbidity burden like chronic kidney disease, cancer, dementia, which makes the drug usage more complicated. Fourth, now we lack the heart failure specific frailty assessment tools, which prevent routine identification and monitoring of frailty status in clinical practice. The trial evidence in frail heart failure patients are not a certainty. We lack randomized clinical trials conducted in frail heart failure patients. In the end, let me conclude my presentation with 4 points. First, frailty is prevalent in heart failure and independently predict adverse events. Second, although many assessment tools exist, none are fully validated heart failure specific tools for frailty assessment. Third, aerobic exercise, cardiac rehabilitation, and guideline-directed medication treatment improves outcome in frail heart failure patients, but these interventions are underutilized. Last, we need dedicated randomized clinical trials targeting frailty heart failure patients to guide evidence-based management. That's all of my presentation. Thank you for your listening.
Okay, thank you, Dr. Yang, for your good topic. So I think yes, you just mentioned the prevalence of the heart failure the prevalence of the frailty in patients with heart failure is very high compared with non-heart failure patients. So it's very important to take more attention on the frailty for those patients. So just mentioned the dilemma of the frailty evaluation and as well as the management with this cohort. So did you have some recommendation for us to, if we do some survey for these for these patients, heart failure patients, did you think what kind of the evaluation, the frailty evaluation to use? Thank you.
Thank you for your question. I think it contains what we used in the clinical background. If we use it in the outpatients, we might use the clinical frailty scale because it's more time consuming. It's not time consuming and quick. And if we do some post hoc analysis, we will use the frailty index because we have collected many data. Yes, and in the clinical background of inpatient, we can use the Fred frailty phenotype because it's more objective.
Okay, thank you. Thank you for your good topic. So do you have some other questions,
No.
Dr. Harry? Dr. Harry, do you have some questions? No.
I don't have any questions. Any other? Dr. Shafiq, any comments?
No, sir, not at present.
Okay. So we'll move to the last talk in this session. It is rehabilitation in chronic heart failure. It is by Dr. T. Jo Yo from National University of Singapore. It is a recorded talk as he is having another meeting. Over to the recorded talk. Can you play it, please?
Hi, a very good afternoon to everyone. My name is Dr. Yo T. Ju, and I'm from the National University Heart Centre, Singapore. Thank you very much to the organizers for their kind invitation to speak today. And my talk is on exercise-based cardiac rehabilitation in patients with chronic heart failure. So the scope of today's talk, I will go through what is exercise-based cardiac rehabilitation based on the definition by the World Health Organization. We have a case example that we can use to see the effects of cardiac rehabilitation in a patient with heart failure. I will go through some of the benefits of exercise-based cardiac rehabilitation and also some of the current guidelines and recommendations. Finally, I will round up with some special considerations in this patient population. So first off, let's briefly go through the differences between the Western world and our population here in Asia with regards to heart failure. So heart failure in Asia tends to happen in people at a younger age and at a higher prevalence than that of the Western countries. So you can see that over here we have a number of Asian countries like Hong Kong, Indonesia, Philippines, Singapore, Taiwan, and all of these are at least 2 to 3 times higher prevalence of heart failure compared to US and Europe. And the mean age of these heart failure patients are also about 10 years younger than those in the Western world. So this tells us that, intervention for our heart failure patients is very important to reduce the potential for or the risk of adverse outcomes. So that brings us to today's topic, which is exercise-based cardiac rehabilitation. So what is the definition of exercise-based cardiac rehabilitation? This definition is from the World Health Organization, and it's a very old but established definition since 1992. I like it very much. So it is actually a coordinated sum of activities. That means it is multidisciplinary between many different teams. And the aim is to influence favorably the underlying cause of cardiovascular disease and to provide the best possible, not just physical, but also mental and social conditions. And with the aim to preserve or resume optimal functioning in the community, and potentially even slow or reverse progression of disease. So this is a very comprehensive definition of cardiac rehabilitation that encompasses many different aspects. Now, in the pictorial format, this is using a brochure that is from my center, the National University Heart Center. So it is actually a multidisciplinary team effort. So cardiac rehabilitation improves, not improves, but rather it comprises of areas that improve behavior, addresses the patient's education, the patient's diet, educates the patient on pharmacological therapy, what they are taking their medications for. For those who smoke, definitely smoking cessation. And finally, why the definition of cardiac rehabilitation is EBCR is because of exercise. So exercise base is the cornerstone of cardiac rehabilitation, comprises of exercise prescription, exercise counseling, and monitoring. So now let's move on to our case example. So this is Mr. XYZ. He is a 50-year-old Chinese gentleman who has been smoking chronically for over 20 years at 10 sticks a day. His baseline medical condition is that of hypertension, for which it is poorly controlled because he defaulted his medication. So in 2022, he actually presented with an anterior ST segment elevation myocardial infarction with also acute pulmonary edema. So the coronary angiogram showed that the culprit vessel was the left anterior descending, for which she underwent a drug-eluting stent implantation. There were also the triple vessel disease because the circumflex and the RCA were also significantly affected. The echocardiogram done during that admission showed that the left ventricular ejection fraction was only 15%, and the subsequent MRI heart done showed that 7 out of 17 segments were non-viable in the LAD territory. So he was started on guideline-directed medical therapy and also referred for coronary artery bypass grafting, but he was undecided at that time. So knowing this background, let's look at how we first recruit patients for cardiac rehabilitation once the condition has stabilized. So you see at the top, acute heart failure or exacerbation of chronic heart failure. I think the earlier speaker would have gone through cardiac rehabilitation for patients hospitalized or in those with acute heart failure. So once things have stabilized and potentially these are patients who have been just discharged, the team will need to screen for some exercise contraindications, as you can see in the red oval over there. And one of these contraindications, so it's a busy slide, but I have highlighted certain contraindications with red star over there. So on the left, you see absolute contraindications, and on the right are relative contraindications. So clearly, if a patient has any of these, one or more of these, we will try not to start or commence any exercise, training, or testing so as not to worsen the condition. Now, on the bottom right, you see that cardiac rehab has excellent safety profile and a very low incidence rate of adverse events. And that is only if you select the correct patient population. So with regards to heart failure specific conditions, you want to make sure that the patient does not have a poor NYHA class. For example, if they are still having dyspnea at rest with NYHA 4 or 3, or if the heart failure has not been adequately managed, the patient is still in fluid overload, then obviously we will not try and exercise the patient. If the underlying condition, which is ischemia, is still ongoing, the patient still having chest pain, even at rest, or with very little physical exercise, then we will not commence cardiac rehabilitation until all these are sorted out. If the patient is, for example, requiring supplemental oxygen or even positive airway pressure because of pulmonary edema, then clearly we don't want to start cardiac rehabilitation yet. And of course, if they desaturate very easily, then we don't want to start as well. For the relative contraindications, sometimes these patients get a lot of new medication, including beta blockers, the ARNIs, and spironolactone and so on and so forth. So their blood pressure may actually drop, and this is a relative contraindication. If they can tolerate this, we can still potentially continue at low intensity. But if not, then we may want to hold off cardiac rehabilitation until they stabilize further. So how do we start exercising, or how do we start cardiac rehabilitation? It starts off with exercise prescription. And exercise prescription is divided into both aerobic and resistance or strength. So this slide shows the exercise prescription for aerobic activity. And if you look at the red oval that I circled, it is broken down into the acronym FIT, or FIT with an extra T. So this is using the American College of Sports Medicine guidelines. So what do they stand for? It's frequency, intensity, time, and type. So whenever you prescribe exercise, it is very convenient to think about this acronym so that you can categorize your advice. So for a typical heart failure patient, we know that they potentially can be quite frail, and their physical fitness can be quite low. So the frequency should not be too overwhelming. It should start off at around 2 to 3 days a week as tolerated. As for intensity, you can see a few parameters here that we can use. So the most basic one is the rate of perceived exertion, or RPE, at a low to moderate level of 11 to 12. If you have the patient's heart rate response or heart rate reserve, you can also use that. And in units which do cardiopulmonary exercise testing to get the VO2 max of the patient, you can be very specific to use the VO2 peak or VO2 reserve. With regards to the duration, it states here about 20 minutes. Actually, if the patient cannot tolerate, you may have to shift it down. So the total duration would be about 15 to 30 minutes, working for about 20 to 30 seconds each time, going as high as about 1 to 2 minutes as tolerated. And you want to cycle different exercises, meaning some parts for upper body, some parts for lower body. So that is the start. And then once the patient is familiar with all the exercises, you can slowly, progressively increase. And you can increase this when you can see that their heart rates are stabilizing, or at the same intensity, their heart rate is actually showing an improving trend that coming down. So that shows that their fitness is actually improving. The same goes for strength. You can also break it up into FIT and T. Again, about 2 to 3 days. It says non-consecutive because you want to give their muscle groups time to recover. Otherwise, they'll feel sore. At the same time, you also want to alternate muscle groups. So no upper body exercises 2 days in a row. Okay. And in this case, apart from the RPE, you use 1 repetition max, which is the amount of weight that they can carry at the maximum amount of weight they can carry for 1 repetition. And once you have that, you use about 30% as a start. And you want low reps and high frequency. Sorry, not low reps, low weights, high repetitions. So about 1 to 2 sets, 5 to 10 repetitions for 4 to 6 different exercises. And at the bottom, the type, you can see all the various equipment that you can use. The easiest is actually the body weight, and then moving to more complicated things like resistance bands, handheld weights like dumbbells, or finally the exercise machines. So in my center, this is what my patients go through, a set of aerobic exercises and then also a set of strength exercises. And we assess them with the rate of perceived exertion score of about 11 to 20. So that again is one of the more basic ways to measure intensity, which is the BOG score. On the right, you can see the score goes from 6 to 20, and this is the actual traditional BOG score. There is a modified version which is easier to understand, which is 1 to 10. So we want to keep it about 11 to 12, which is low to moderate. We don't want to push it too high in case of adverse events. And this is also the most universal because not everyone have heart rate monitors that can measure their heart rates accurately. So the thing about BOG score is that it requires calibration because it is not intuitive. Not everybody will understand when you say, what is your BOG score 6 or exercise at the BOG score of 10. or when you see the patient exercising, you may ask them, oh, what is your box score now? So, for example, if a patient is panting and very breathless and they cannot push anymore, you ask them, what's your box score? And then they may say, oh, it's 7. On the contrary, when you see a patient looking very relaxed, chatting away, and you ask them, what's your box score? And they say 20. So you may need some calibration to say that, okay, this intensity corresponds to this box score. So it takes some effort. So moving on to the whole reason that we do exercise-based cardiac rehabilitation, which is the benefits of cardiac rehab. So this is taken from a recent paper just published last year in Circulation Research. The reference is at the bottom. So it summarizes the amount of evidence available for both heart failure with reduced as well as heart failure with preserved ejection fraction. To date, there is a lot more evidence for heart failure with reduced ejection fraction, and exercise training clearly reduces mortality as well as hospitalization. This is adjusted, mortality. The VO2 max or exercise capacity increases, and the quality of life also increases both in terms of mood as well as the short term. There is insufficient evidence to talk about long-term quality of life improvements, and all this is for heart failure with reduced ejection fraction. As for heart failure with preserved ejection fraction, the evidence is still accumulating, but to date, at the very least, it shows that there is improvement in repeat hospitalization in terms of reduced events, as well as improvement in peak VO2 and quality of life. There is still not enough evidence for mortality benefit, but I think if we, once there is a proper way to do analysis with larger sample size, we should see, some beneficial effects there. Now, this is a busy slide that comes from the same summary review paper in Circulation Research. This talks about the physiological effects and what are the mechanisms that underlie these effects. I will not go through this in detail, but you can see that multiple organ systems benefit from exercise training. The lungs, the heart, for inspiratory muscle strength, VO2 max, cardiac function, ejection fraction actually improves. There is good remodeling. The vasculature actually improves. Endothelial function improves. Skeletal muscle improves. There's less atrophy. Later, we will talk about how this is very important, especially with the concept of frailty. And then, of course, the global effects, the overall effects on inflammation is beneficial as there's anti-inflammatory effects. The nervous system also gets better in terms of reduced sympathetic activity. So all in all, with regards to the available evidence and the mechanisms of benefit in terms of exercise, heart failure cardiac rehab is highly recommended. So on the left, you see the American guidelines, and on the right, you see the European guidelines. And both recommend at class 1 and 2A exercise training and cardiac rehabilitation for patients with heart failure. Now, coming back to our patient, he completed 8 sessions of cardiac rehabilitation within about a month at twice a week. He remained at NYHA class 1. His 6-minute walk test distance actually improved significantly, almost by 200 meters. His heart rate walking speed index improved from 0.99 to 0.78. So this heart rate walking speed index is something that my center uses, where we measure the heart rate for every minute of the 6-minute walk test, and we use the speed, we index it with the speed. So a lower heart rate walking speed index means that the heart is pumping more efficiently at the same speed. Subsequently, we know that 8 sessions is definitely not enough for any patient, let alone a heart failure patient. So luckily in Singapore, we have a community cardiac rehab center that we can refer them to, which is our Singapore Heart Foundation, so that they can continue long-term community cardiac rehabilitation. Repeat scans subsequently showed that the left ventricular ejection fraction has some improvement to 25 on the echo and 32% on the MRI. So quickly, just some special considerations for heart failure patients. We all should bear in mind potential for arrhythmias, which is why especially if those with reduced ejection fraction, we put them on telemetry. We must always be mindful when they come into the exercise rehab, whether they have any new heart failure exacerbation. They could have taken a lot of salt, drank too much water, and they come in overloaded. They also have potential for abnormal blood pressure and heart rate responses. We must also bear in mind their comorbidities like hypo and hyperglycemia if they have concurrent diabetes. And importantly, their mental health. Some people can be depressed, can have a lot of fear and anxiety. And with that, a role of a peer support group or patient support group is very important. So if you have something of, that peer support group in your center, please refer the patients for that as well. So I mentioned the word frailty earlier on, and that is very important. This is getting more and more traction and more emphasis, especially in those with heart failure, because the vast majority of patients with heart failure do have concurrent frailty, and that also may contribute to depression. So the updated definition of frailty, again, just in a recent paper from ESC Heart Failure, states that it's multidimensional, it is dynamic, and it is importantly potentially reversible. Also, it is independent of age. So just because your patient is a bit younger doesn't mean that they are not frail. So they can be young and also frail, and that makes the patients more vulnerable to heart failure adverse outcomes and poor outcomes. This is a summary, basically a score that the heart failure, published in the ESC Heart Failure Journal. There is a 10-point scale or 10-point assessment for people to assess whether the patient is frail, not just clinically, as you can see by the number of comorbidities, whether they fell down or had weight loss, but also functional, psychocognitive, and social. So these 10 questions are something that you can actually keep in mind, a short assessment of your patient to see whether they need additional help, with referrals to, for example, occupational therapist, psychiatrist, social worker, or whether they need additional emphasis on strength training, for example. Last bit on the true status of cardiac rehabilitation. So this is from the Inter-Aspire study and consists of 14 countries. And this is not even cardiac rehabilitation for heart failure, but cardiac rehabilitation in general for coronary artery disease. Only 27% of countries referred patients for heart rehab, and only 9% of patients actually attend. So if you extrapolate, the heart failure population will be much less than this, and we have a lot of work to do to catch up. So we have reviews like this that say that heart failure rehab should be the 5th pillar in management alongside the guideline-directed medical therapy. And I fully agree. So this is a review paper that we did, and it tries to summarize that cardiac rehab is relevant and important for all types of heart failure. And these are the different benefits, but there are many barriers, including lack of awareness, cost concerns, special populations like the minorities, low health literacy, and poor motivation. So hopefully in conferences such as this, we raise the awareness of the importance of cardiac rehabilitation such that many more patients can be referred. So in conclusion, the prevalence of heart failure in Asia is high. The functional and exercise capacity are often much reduced in heart failure. You have to look out for frailty and depression with some new summarized score systems. Exercise-based cardiac rehabilitation is established, is evidence-based, and it should be performed in all patients who have no contraindications, and it can improve the quality of life, functional capacity, and reduce cardiovascular mortality and hospitalizations. With that, thank you so much for your attention.
Since Dr. Gito he was absent, thanks to him. Any comments or questions from Dr. Shafiq? Final, can you wrap up the session and Shafiq, can you hear me? Can you give the overall? You're muted.
Yeah.
Now is better. Yeah.
I think it's very good presentations, and we have understood that heart failure an important part of treatment is rehabilitation, and it is a continuum which starts when the patient is admitted, and it goes into the community as well as in the hospital, as shown in one presentation that a community-based with the hospital as a center point. I think we can reach out to many patients in this regard. Very good presentations overall.
Yeah, I think it's a very cost-effective solution to have this rehab program. So I think it is almost equally effective to many of the so-called pharmacological and device therapies to some extent. So in that way, rehabilitation is a very useful thing. I think we should incorporate this into our routine clinical practice, which can be done it can be do this in a very simple ways. So with that conclusion, I'll close the session. We have had a good discussion. Thank you, everyone. See you sometime later. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.